Good morning to you all, and thank you, Dr. Shishir and Amit, for giving me a chance to present our experience on how do we approach a patient with pan-uveitis. Now, this talk will be a summary of the previous talks because pan-uveitis is defined as inflammation of the anterior chamber, vitreous, the intermediate zone, the retina, or the choroid. And this is as per the latest SUNS classification of uveitis. So when we see a patient with pan-uveitis, there are many causes. Usually, we divide it into either it could be infectious, which is quite common in our part of the world because TB is endemic. And then you have a non-infectious. Again, this can be divided into with retinal detachments and without retinal detachments. And without retinal detachments, we need to keep in mind sarcoid, which we are seeing more often these days, Behçet's, and sometimes even the Fuchs heterochromic iridocyclitis, if it's bilateral or unilateral, it can look like a pan-uveitis. And if it is with an RD, the high probabilities that it could be a VKH or sympathetic ophthalmia. And of course, masquerades is something which we should always keep in mind, especially when we are dealing with extremes of ages. In the infectious group, we see tuberculosis, which is very common. Syphilis is something which is beginning again on the rise, so we'll need to keep that in mind. Viral uveitis can present as pan-uveitis, especially what Dr. Padma showed, the CMV retinitis, where you can have an immune recovery component. And you can have toxoplasma, especially if it is undiagnosed, you can have it as pan-uveitis. And of course, you have endophthalmitis, chronic endophthalmitis, which can present as pan-uveitis. And in certain areas, leptospirosis is very common, so we need to keep in mind, again, if there's an outbreak, we need to keep that as well in mind. Now, whenever we look at any case of uveitis, there are three things which we need to keep in mind. One is the age, one is the geographic area the patient hails from, social factors, and what is the presentation like, which mainly includes history and examination. History is very, very crucial when we are dealing with patients with pan-uveitis because it is very important to elicit, which gives you details on how you can go about looking at these cases. So first important thing is you should elicit appropriate symptoms. And all these like loss of weight or appetite may not be very important for the patient, but it will be important for you. History of any intravenous fluids or the course and onset. As many diseases like TB, Sarcoid are very chronic. And what Padma had mentioned about Behçet's, it's very explosive. The patient will come characteristically saying, suddenly there is a drop in vision or there are black spots in front of my eye. So these are important things which we need to keep in mind. And of course, systemic diseases, the patient may not disclose it to you, but it is important for us to look at the patient very carefully. Look for vitiligo patches, genital ulcers. Is the patient immunocompromised? And of course, always get all the old records with the patient because that will definitely give you clues in managing the patient, and it will also give you sources of inflammation. Again, examination, I cannot overemphasize, it will be ocular and systemic. And three important things when we look at the patient in terms of examination ocular is look at the clinicopathological pattern. Are we dealing with granulomatous? Are we dealing with non-granulomatous? Is there any specific clinical patterns? And always it is important to look at the adjacent structures because this will give you a lot of clue. In the systemic examination, the physical appearance itself will give you a clue, and it is also once probably you get a provisional, you can go back and review the systems once again. And of course, the investigations, I'm not going very much into detail, but any case of pan-uveitis, I would like to do, especially granulomatous, the use of CT instead of a chest X-ray is very, very useful. And of course, these are all the other investigations which we normally do in patients with pan-uveitis, again, depending on what you're thinking. So let me just discuss this case. This is a 37-year-old lady. She's a physiotherapist. And she came to us with a history of blurring of vision, pain, difficulty to open her eyes since the last 6 months. Now, she has been on and off on topical steroids, and she's even had, as per her records, an increased intraocular pressure, for which she was on Timolol eye drops twice a day. Now, when she came, she just could not open her eyes. She had so much of photophobia, and she was in quite a bit of discomfort. Now, this is a very important clue because I will show you why. On examination, her best corrected visual acuity was 660 in one eye and 618 in the left eye. So this is the eye. This is very typical. You have granulomatous uveitis. Again, you have KPs, iris nodules, which are here, broad synechiae. And of course, her tear meniscus is very low. And posterior segment also, she had severe vitritis and disc hyperemia as well. So a simple test would give you a diagnosis here. So we just did a Schirmer, and the Schirmer was very low. It was 0 and 1. Now, when you have a pattern like this with a dry eye, the most important thing is sarcoid, which we need to keep in mind in pan-uveitis. And a quick look at the fornix, she had this conjunctival granuloma. So then you go back and ask her, does she have any skin lesions? And then she lifts her leg and shows she has all these lesions, which she thought it's not important, and she thought it's just a bite. So this is the Erythema Nodosum, which she's having. And at this point of time, we got her a CT done, and she has these large lymph nodes in the thoracic region and also changes in the lung. And instead of going to the CT to biopsy, you can just biopsy the conjunctival granuloma, which showed chronic granulomatous lesions and non-caseating granuloma. And a quick look into the blood investigations had the serum ACE, which was so high, ESR high, MAN2 negative, quantiferon negative, and she had a pulmonary lung function. So here the diagnosis was so obvious from the very beginning, and the investigations just added on to the case. So this was a case with sarcoidosis, which very clear, commonly, especially in the pan-uveitis stage, presents with keratoconjunctivitis sicca, and this patient had granulomatous uveitis. And this patient was started on steroids and now on methotrexate and is doing extremely well, that in fact we don't even see her regularly now. Now, these are the different manifestations of sarcoid, pan-uveitis. Again, one of the most things which we tend to miss. It can also come with vitritis with just non-granulomatous uveitis, again, granulomatous uveitis, conjunctival granulomas, and iris nodules. And very rarely you can even see scleral nodules. In the posterior segment, you can have vitritis, pars plana exudates. You can have this kind of candle wax dripping. This is one of the features which you can differentiate it from tubercular pan-uveitis, because that comes with more of occlusion. And you can have solitary choroidal granulomas or multiple choroidal granulomas. We also see depigmented areas with something like a Dalen fuchs in sarcoid as well. And of course, you can have discedema, disc granulomas in these patients with sarcoid-associated pan-uveitis. They usually have a negative MAN2, positive chest X-ray, but nowadays we are moving on more to the CT, and CT usually shows symmetrical enlargements in the mediastinal lymphadenopathy and hilar lymphadenopathy. And if you can biopsy, that is the best, which shows non-caseating granulomas. Now, in contrast, we also see TB-related pan-uveitis, and usually it is associated with multifocal choroiditis like this. You can have intermediate uveitis. Usually it's unilateral, but you can also have asymmetrical bilateral. You can have these kind of granulomas along the blood vessels like what Dr. Sudarshan showed, or these kind of scars along blood vessels. So if you see a pan-uveitis with this kind of features, you're more likely to think it is tubercular. They usually have a positive MAN2. They have a heterogeneous enhancement on the CT lymph nodes, and this is usually why we get a CT instead of an X-ray done. And you can biopsy these lymph nodes. You can have caseations, or you can look for any changes in the cervical lymph nodes, and you can biopsy that, and you can see caseating granulomas. Now, this is another case. This is a case of a VKH. I'm just showing a classic pattern here. Again, you can have serous detachments in the setting of a granulomatous uveitis. And then the investigations you order will be fluorescent angiogram and the B-scan, which shows thickening. You can have the pinpoint leaks with pooling. The most important is the OCT, which shows these kind of RPE bumps, which is very characteristic of VKH. And look for vitiligo patches, and or you look for the other eye, which is thicical or has had previous surgeries, then it is usually sympathetic ophthalmia. Many times when it is not treated adequately, you can have this kind of a Dalen fuchs nodules in a sunset glow fundus. These are classic characteristic patterns. And if you find something like this, you're going more towards VKH or sympathetic ophthalmia. Again, Dr. Padma mentioned Behçet's. Again, the history is very characteristic. This is the classic pattern, hypopyon with vitritis. You can have retinitis. These fern-like leakages, choriocapillary leakages on the fluorescent angiogram, and this patient had retinal vasculitis, and she had an occlusive arterial occlusions basically, and this patient turned out to be Behçet's. Again, you will have to ask them because they are very reluctant to tell you, so you will have to look for mouth ulcers or genital ulcers. and this is a patient with Behçet's. So ultimately, when you see a patient with pan-uveitis, it's more of putting together your history, your symptoms and signs, like as if you're solving a puzzle. And I keep telling in all my lectures that uveitis is that branch of ophthalmology which is very close to medicine, and you need to deal with experts from the other fields of medicine as well. So I joined Padma in inviting you all for the UCCon next year, which is going to be in Bangalore. Thank you so much, Dr.